Hello, everyone. I'm Dr. Sashwanti Mohan. I practice in Dubai and Medcare Eye Center. And today we'll be talking about retinal vein occlusions and from recognition to management. So, retinal vein occlusions, as you know, it's defined as an obstruction of a retinal venous outflow, which leads to blood backup in the retinal veins, increased venous pressure, and secondary retinal changes, which can include retinal hemorrhages, macular edema, and retinal ischemia. Why does RVO matter? And it's such a big topic, very difficult to cover in 45 minutes, but I'll do my best. But RVO matters because it has a wide global impact, affecting about 16.4 million people worldwide. It is also the second most common retinal vascular disease after diabetic retinopathy. BRVO, that is branch retinal vein occlusion, is 5 times more common than CRVO, and it has a leading cause of sudden painless vision loss in older adults with a significant treatment costs and follow-up requirements. And this is why recognizing and treating this accordingly is very important. Let's first look at the anatomy. So the normal retinal venous anatomy starts with the retinal capillaries, which is the smallest venous channels. It leads to the retinal venules, which is formed by the convergence of these capillaries with a little larger diameter. And these lead to branched retinal veins, which are the major tributaries draining certain sectors, different quadrants of the retina, with a diameter of 80 to 150 microns. The central retinal vein is the single trunk exiting through the lamina cribrosa. You can see the picture below. The central retinal vein and the vessels are surrounded by the lamina cribrosa with a diameter of 200 to 250 microns. And then they go on to the ophthalmic veins and the cavernous sinus. Arteriovenous crossings are very important because they are characteristic anatomical sites where the retinal arteries, they cross over the retinal veins, and this creates a potential compression point. The venous wall loses its muscular coatings at these crossings. Lamina cribrosa is important in central retinal vein occlusion because it is a perforated region of the sclera, allowing passage of the central retinal vessels and optic nerve fibers, and it's composed of collagenous beams forming about 200 to 300 pores. It's important to know the anatomy before we go on to the pathophysiology. Very easy to remember. It's called the Virchow's triad, and it's because of venous thrombosis due to stasis, vessel wall injury, and hypercoagulability. So, due to these hemodynamic changes and vessel wall changes and blood composition changes, it leads to the development of a thrombus formation and venous obstruction, which is characteristic of RVO. So, important point is Virchow's triad, and we need to tackle all these causes to prevent RVO. So, coming to the first polling question, what is the most common risk factor for retinal vein occlusion? Is it A, diabetes mellitus, B, hypertension, C, smoking, or D, hyperlipidemia? They're all causes, but what do you think is the most common one? Yeah, so the majority of you, 48% of you have said hypertension, and that is right. Hypertension is the commonest cause of retinal vein occlusion. So let's move on. So 85% of the patients of hypertension is the cause of the hypertension. 60% is diabetes, 45% dyslipidemia, and of course, age factors. Cardiovascular hypertension is the most significant modifiable risk factor. It leads to arteriosclerosis and atherosclerotic disease progression, and also leads to cardiovascular disease and coronary artery conditions. There are metabolic causes such as diabetes. It's also an important cause, like many of you said, but not as important as hypertension when it comes to RVO. And it also hyperlipidemia, dyslipidemia, obesity, metabolic syndrome, and advanced age. There's also male predominance in younger RVO patients. Smoking is very important. There are also hematological alterations like hyperviscosity syndromes, blood dyscrasias and malignancies, chronic renal failure, dehydration, pregnancy, high body mass index, etc. are also very important causes. There are also ocular risk factors. We just spoke about systemic risk factors, but we also have ocular risk factors. One of the most important risk factors is glaucoma because it's an increase in intraocular pressure, which compresses the central retinal vein at the lamina cribrosa, like we saw in the photo. So there's a 3.5% higher risk ratio versus in normal population. Ocular hypertension, which is another form of glaucoma, is another cause. Short axial length due to crowded optic disc anatomy, and disc drusen due to mechanical compression can also contribute to RVOs. It also can occur after retrobulbar blocks that we used to give during cataract surgery. It's not as commonly done now, but still need to be aware of this in case a parabulbar block goes retrobulbar. And very important subset and cause that we need to rule out is RVO in young patients. So these are uncommon causes, especially suspected in patients who are much younger, that is less than 50 years of age. hypercoagulable states, inflammatory conditions such as Behçet's, sarcoidosis, and SLE, oral contraceptive usage, diuretics, pregnancy, hyperhomocystinemia, protein S and C deficiency. So when to suspect systematic disease, bilateral involvement, recurrent episodes, and associated systemic symptoms. We will talk about the workup later. I will go into more detail about it, and but it's important to always identify RVO in young patients. So coming to the classification of central retinal vein occlusion, it the most important one is CRVO, that is central retinal vein occlusion. The main central retinal vein is affected. It can be non-ischemic CRVO or ischemic CRVO. You can also have branch retinal vein occlusion, which affects a sectoral, that is a quadrant that is supplied by a branch retinal vein. This can be major or macular BRVO. You can also have what we call as minor BRVOs, which is tributary retinal vein occlusions. Then there's hemiretinal vein occlusion that is affects superior or inferior retinal of the retina. And this can also be non-ischemic or ischemic. You can also have combined CRVO and CRAO, that is arterial occlusions. However, I'm not going too much into arterial occlusions because there's not enough time to cover arterial occlusions in this session. So what are the symptoms of retinal vein occlusion? The patient will typically present with a sudden but painless visual loss. So important to remember, it's usually painless, the vision loss. The unilateral visual fields will develop typically over hours to days. Visual disturbances may also include central scotomas, peripheral vision loss, or even metamorphopsia if they have macular edema. A characteristic feature, sometimes patients may complain about curtain coming down or gray cloud over the vision with a complete absence of pain. So whenever a patient presents to you in OPD, and I had a lot of questions even before the webinar, optometrists asking what should we do to make sure that we don't miss these patients. Are any patient complaining of sudden painless visual loss has to be made, we have to make sure we're ruling out retinal vein occlusions. So again, I will show you more pictures later. Clinical signs will include retinal hemorrhages, venous dilatation and tortuosity, cotton wool spots, macular edema, hard exudates, etc. Let's talk about this one by one. We will start with central retinal vein occlusions, which has a prevalence of about 0.1 to 0.4%, and male and females are equally affected usually. Age can be greater than 65 years. Again, usually we do see, of course, CRVO in young as well. And an annual risk of developing CRVO in the other eye is 1%. So it's very important we don't just look at the eye with CRVO. We also look at findings in the other eye. This occurs due to occlusion of the lamina cribrosa level, which affects the entire retinal venous drainage, causing diffuse retinal hemorrhages, cotton wool spots, and venous engorgement in all the quadrants. So what is the pathogenesis? There are three primary pathogenesis. There is occlusion of the vein by external compression due to sclerotic adjacent structures. Occlusion by primary venous wall disease, it can be either degenerative or inflammatory, or any kind of hemodynamic disturbances produced by a variety of factors that can be arterial spasm, blood dyscrasia, etc. Another important another important part in the pathogenesis is nocturnal arterial hypotension. Some patients wake up with poor vision, which strongly suggests that this can play an important role. So if you look at this picture, which is again available online, orbital diseases, hypercoagulable states, glaucoma lead to venous stasis, which leads to thrombus formation. And there's also endothelial damage mediating the thrombus formation secondary to vasculitis, which can lead to CRVO. Now, CRVO can be either ischemic or non-ischemic. You can always take a picture of this slide, but I will talk about it more in details in the next slide. So the fundus appearance in CRVO, we typically call it as a blood and thunder appearance, but it does not have to happen in all patients. Why is it called blood and thunder? Because there are diffuse retinal hemorrhages in all quadrants, giving the characteristic splattered blood appearance. There's marked venous dilatation and tortuosity of the retinal veins. Sometimes you can see optic disc swelling with blurred margins. You can see cotton wool spots scattered throughout the posterior pole. Again, it's not always a must. You can see it in some patients. And sometimes you can see macular edema, which can contribute to vision loss. So the term blood and thunder, again, originates from the dramatic fundus appearance. I'll show you a picture later, which resembles splattered blood against a stormy background of venous engorgement and retinal edema. So you can see in this picture, not typical blood and thunder, but you can see there are a lot of retinal hemorrhages throughout the entire retina. It's going till the peripheral retina, including the macular and the posterior pole area. There's also marked venous dilatation and tortuosity. You can see all the veins are very, very dilated, and there's no typical cotton wool spots or optic nerve, optic disc swelling in this, but this is obviously a case of retinal, central retinal vein occlusion. So let's come to the polling question two. Which feature best differentiates ischemic from non-ischemic CRVO? Is it A, severe macular edema on OCT, B, extent of retinal hemorrhages, C, presence of RAPD, or D, marked venous tortuosity? Okay, so many of you, again, majority is chosen presence of RAPD, and that is the right answer. But I guess it's people are confused about why it is because it's not too much of a majority. So let's look at it. So in non-ischemic versus ischemic CRVO, you can see this typical findings between these two. Of course, there are some cases which you may not suspect, but it can be ischemic. But usually what we look at is first visual acuity. Non-ischemic CRVO usually has a mild to moderate visual loss, then vision is most of the time better than 6 by 60, whereas ischemic CRVO will have severe loss that is less than 6 by 60. RAPD, which is the most important factor, and that is another important point for optometrists to pick up because I did get a lot of questions about this, is presence of RAPD. When RAPD is present, and typically it is greater than 0.7 log units of neutral density filter, it is suggestive of ischemic CRVO. Whereas in non-ischemic CRVO is usually absent or very, very mild. So there are grades to RAPD, and ischemic CRVO will have a very strong grade. The fundus appearance is not very reliable. Non-ischemic CRVO typical cases have fewer hemorrhages or cotton wool spots, whereas ischemic CRVO is supposed to have dense blood and thunder, multiple cotton wool spots throughout the entire fundus. But this is not a very reliable feature. You can see, opposite sometimes in RVOs as well. In FFA findings, you will see less than 10 disc diameters of non-perfusion in non-ischemic CRVO, whereas in ischemic, it will be more than 10 disc diameters. ERG is also an important investigation, but it's not available everywhere. But if you do have the availability and you need to differentiate, ERG is near normal or mildly reduced amplitude with the preserved B's to A ratio, whereas it's markedly reduced BV amplitude in ischemic CRVO. Macular edema is common in both, but it is often more severe due to ischemia in CRVO. Neovascular risk is obviously higher in ischemic, and neovascular glaucoma is obviously higher. And visual prognosis is poorer in ischemic CRVO and requires closer and longer term follow-up. So conversion to ischemic CRVO occurs in 15% of cases within 4 months and 34% of the cases within 3 years. So it is important that even if it's a non-ischemic CRVO and you're 100% sure it is non-ischemic and there is no macular edema, you still have to follow up the patient because at any point they can convert to an ischemic CRVO. So again, why this distinction matters, an initial stage, there's preserved capillary perfusion in a non-ischemic condition, and due to multiple risk factors, and the conversion rate is 15 to 30% within 3 months, and there's widespread capillary non-perfusion in ischemia, which can lead to occurrence of neovascularization in 20 to 40% of the cases within 6 months. So visual prognosis is better in non-ischemic, and treatment approach usually non-ischemic. If there's no macular edema, it's observation. Whereas in ischemic, if there's macular edema, we do anti-VEGF, and if there is NVE, NVD or NVE, we do pan-retinal photocoagulation. I'll talk about the treatment options a little later. And follow-up is also more often in ischemic, monthly, whereas non-ischemic can have a little slower follow-up, and complication risk is higher in ischemia, ischemic CRVO. So coming to branch retinal vein occlusion, this occlusion occurs at arteriovenous crossing points, typically affecting the supratemporal quadrant. So this results in sectoral retinal hemorrhages just only in the quadrant draining that where the vein is draining, and edema is limited to the affected drainage area. So visual prognosis is better than CRVO because the entire retina is not involved, and the mechanism is slightly different where it involves arteriovenous compression, where the artery compresses the vein at the crossing points. So this brings me to polling question 3. We often say supratemporal quadrant is the most common site, but why is it so? A, it has the highest number of arteriovenous crossings. B, venous flows naturally slower in this quadrant. C, the artery always lies anterior to the vein here. Or D, higher intraocular pressure preferentially affects this quadrant. So what do you think the answer is? So the answer is, again, majority of you have chosen the right answer. It has the highest number of arteriovenous crossings. This is a very, actually, for people who are ophthalmologists going for exams, is actually a very popular question in Vivas. So let's move on. So arteriovenous crossing changes are very important in BRVO because there's an arteriosclerotic vessel wall thickening which exerts a mechanical compression on adjacent veins. And this compression, what it does is it creates a turbulent blood flow pattern at the crossing site, and it predisposes to venous endothelial damage and subsequent thrombosis. And this is exacerbated by the shared adventitial sheath that binds the artery and the vein. So this is very important. There's a common adventitial sheath which explains why BRVO typically occurring at these crossing points where the arterial stiffening directly impacts the venous hemodynamics. The fundus appearance in BRVO, as you can see in the picture, there is a sectoral involvement depending on which quadrant is involved. Hemorrhages are limited to that quadrant. Venous dilatation is confined to that occluded branch. Cotton wool spots in that drainage area. And macular edema if the macula is involved. And again, the most common location is supratemporal. Coming to collaterals, we often see these pre-existing venous channels that dilate and become functional to bypass the obstructed vein in RVO. So you can see in this picture, in this supratemporal area, you can see sclerosed vessels, and you can also see these loopy vessels which are connecting these veins to these sclerosed vessels. So what are they? They are known as collaterals, and they are very important in RVO because they improve the venous outflow. They help drain blood around the blockage, reducing the venous congestion. They reduce macular edema. They cause better outflow, less capillary leakage, and improved or stabilized macular edema. They have better visual prognosis because of less ischemia and more stable vision and lower long-term complication rates. And it's a marker of chronicity and not activity. So collateral suggests that the eye is adapting rather than worsening. So it's a very nice natural mechanism of the eye to combat RVO. So this is actually a patient who presented with the other eye. She had some issues with the other eye, and she didn't have any issues with this eye because her vision was 6/6, and she never even realized she had an RVO because the eye itself has compensated, and she never developed macular edema or anything else. But of course, she needs close observation because that area is ischemic and can develop neovascularization in the future. So based on collaterals, and this is a very important question, how do you treat them? Do you do laser? Do you do anti-VEGF? Do you do steroids or do you observe? So this is the polling question 4. How do you treat the collaterals? Laser, B, anti-VEGF, C, steroids, or D, observe? We do not touch these collaterals. They are excellent natural mechanism of the eye to combat RVO. So collaterals are not neovascularization. It's very important to differentiate between the two. They do not leak on FFA like NVE do, and they do not lead laser or anti-VEGF. And their presence does not mean treatment failure. They indicate a favorable natural course. So all we need to do is observe. We do not touch them in any other way. So coming to hemiretinal vein occlusion, it is not as common as CRVO or BRVO, but we do see it. The less common hemicentral occlusion involves one trunk of a dual trunked CRV. So earlier it was thought that it was like a variant of BRVO, but then they realized it is the central retinal vein, which is dual trunked in some patients, that has persisted in the anterior part of the optic nerve head and as a congenital variant. So it either involves a superior or inferior retinal hemisphere. So it's an intermediate condition between the two. And the severity of venous outflow obstruction and extent of retinal involvement and visual prognosis is in between CRVO and BRVO. So it affects half of the retinal venous drainage system. It's more extensive, CRVO, whereas it's more extensive but better visual prognosis, and BRVO is more localized but with higher risk of macular edema. So in all cases of ophthalmic examination, another question for the optometrist or any of the residents who are first seeing a patient before dilating the patient is visual acuity. It's very important because as we know, non-ischemic versus ischemic CRVO, visual acuity does play a role in differentiating them. Slit lamp examination is very important. We need to look at the angles of the eye, any neovascularization, and any neovascularization of the iris or the angles. So gonioscopy has to be done to make sure we're not missing out neovascularization of the angles. We have to check for RAPD. It's a very important sign. It's the most important sign in ischemic versus non-ischemic CRVO. Intraocular pressure. So fundus examination, of course, OCTA and fundus fluorescent angiography. We'll talk about them in the later slides. And of course, systemic evaluation. Once you diagnose the patient with RVO, we need to rule out any systemic conditions. So blood pressure, ESR, complete blood count, blood glucose, lipid profile, plasma protein electrophoresis, renal function tests, cardiac echo, ECG, etc., to rule out any kind of underlying disorders. In young patients, the workup is more important, and in bilateral RVO, any previous thrombosis or family history of thrombosis, and in patients on whom investigation for the common associations. Let's say we've ruled out blood pressure, we have ruled out dyslipidemia, we ruled out diabetes. Now we need to investigate a little further. In this, we do a hypercoagulable panel where we do protein CS, antithrombin 3, factor V latent mutation, prothrombin gene, C-reactive protein, serum homocysteine. One of the most common causes of a young patient with CRVO is serum homocysteine. Then autoimmune markers can also be done. Serum angiotensin converting enzyme, chest X-ray to rule out sarcoidosis, tuberculosis, cardiac evaluation, and neurological assessment when needed. So age-specific considerations are very important. More aggressive risk factor modification should be done in these patients. There should be a longer treatment duration in case needed, in case anticoagulation is needed. And fertility considerations are also important because sometimes OCPs and pregnancy itself can cause RVO. So we need to use warfarin alternatives in childbearing years. And long-term prognosis, there's a higher risk, recurrence risk and requires extended surveillance in these kind of patients. So what is the role of OCT? Macular edema, which is very common complication of RVO, the assessment of this is very important, not only for diagnosis, but also to see if your treatment is working or not. So it is a gold standard for detecting and monitoring macular edema. It quantifies retinal thickness with micron level precision. It identifies cystoid spaces in subretinal fluid and guides treatment decisions and monitors therapeutic response. It has obviously advantages over clinical exam because it gives you an objective measurement. It tells you exactly what the thickness of the central retina is. And also it also detects early subclinical changes and also helps in treatment monitoring, like I said. So what are the most common OCT findings in RVO? You might have seen a lot of diabetic retinopathy. Even RVO might have very similar findings of cystoid macular edema with a honeycomb pattern. You can see the first picture on the top with hyporeflective intraretinal cysts. Persistent cysts correlate with poorer visual outcomes. Subretinal fluid, that is accumulation of fluid between the photoreceptors and the RPE. The SRF resolves faster than intraretinal fluid, but may indicate more severe ischemia. You can also have drill, that is disorganization of the retinal inner layers with loss of normal laminar architecture, which is a poor indicator that there's a poor prognostic significance. And increased central retinal thickness, of course, more than 300 microns indicates active disease, and thicker baseline CRT predicts slower recovery. There can also be presence of hyperreflective foci, that is microglial activation or hard oxalates, and may represent ongoing inflammation or lipid deposition. So let's look at this OCT here. You can see obviously significant retinal thickening, and you can see subretinal fluid as well, and you can see cystoid spaces in the retina, and you can see there is drill. That is, there is disruption of the retinal inner layers, which means the prognosis in the eye is slightly poor. So when you explain to the patient that we're going to give anti-VEGF in your case, we do have to explain the prognosis as well. So this table, difficult to go through the entire table, but you can take a quick picture and obviously it will be available online. This gives you a very good idea about which OCT biomarker is good prognosis and which OCT biomarker is a poor prognosis. So of course, intact ellipsoid zone, which means the outer retinal photoreceptors are preserved, is a good visual potential, for example, and drill or ELM or EZ disruption, where you know there's a photoreceptor damage, will end up with poor visual acuity, even if the macula is dry. So it is important to look at your OCT, not just see the thickness and leave it at that. You need to look at all these OCT biomarkers to make sure that you're explaining to the patient, and you know the visual improvement is also explained. Okay, you may or may not get visual improvement because there is loss of EZ or loss of ELM, and it's not just drying of the macula that is important after treatment. Another important investigation, of course, is fundus fluorescent angiography for assessing the capillary perfusion status, differentiating ischemic versus non-ischemic conditions to detect especially retinal neovascularization, because FFA is the gold standard for detecting retinal neovascularization in case you cannot see it clinically, and to guide laser photocoagulation, especially in BRVO, and evaluate treatment response and disease progression. So it provides a dynamic visualization of the retinal and choroidal circulation with high sensitivity for vascular abnormalities like RVO, and that's why it's very important in RVO. So when do we perform FFA and RVO? We perform it after the acute phase is over. Let's say a patient presents with you with full blood and thunder retinal hemorrhages. FFA is useless in this patient because FFA will just show blocked hemorrhages, and you need to wait for the acute phase. So typically they say about 3 months after the development of RVOs, when we perform it, we look we do it to look for any macular ischemia by looking at the foveal avascular zone, to evaluate the extent of capillary non-perfusion. In case of non-ischemic CRVO, to follow up changes that can be identified, such as conversion to ischemic type, and to differentiate neovascularization and collaterals in case of cases which are very confusing, where you're not sure if it's collaterals or neovascularization. Then FFA neovascularization will leak, whereas collaterals will not leak. So these are the FFA findings in RVO. You can see there can be some disc leakage. And in the second, third, and fourth picture, you can see hyperfluorescence due to hyperperfusion, that is capillary non-perfusion and retinal ischemia. You can also have hyperfluorescence due to blockage, which can be due to intraretinal hemorrhages. And that's why it's preferable to do it once there's a resolution of retinal hemorrhages, so that you'll be able to identify actual capillary non-perfusion. The FFA will also show delayed filling in the venous phase of the angiography, and retinal veins will appear dilated and tortuous, and AV time is also prolonged. So, like I said, collaterals will not have leakage, and neovascularization will have leakage. And late phase leakage appears as hyperfluorescence from damaged retinal vessels and neovascular complexes. So you can see in the second picture here, you can see this neovascularization, which is increasing in hyperfluorescence and suggesting of leakage. So for BRVO, 5 disc areas of non-perfusion indicates a 40% risk of retinal neovascularization in 3 years. And for CRVO, 10 disc areas of non-perfusion were associated with a 35% risk of iris neovascularization at 3 years. So capillary occlusion of greater than 10 disc diameter can be used as FFA characteristic to distinguish between ischemic and non-ischemic CRVO. So that is approximately 50% of the retina in the 30-degree exposures. So it is very important to do FFA, and we have to choose exactly which phase to do it, so that we are not wasting an invasive investigation on a patient. OCTA is obviously one of the newer technologies available, may not be available everywhere, especially not very easily available in developing countries. But OCTA can, if it's there, it's also a useful investigation modality. It can identify macular ischemia, can show you an enlarged FAZ, as you can see in the picture below. It can show you ischemia in the superficial and deep capillary plexus. It can show you NVE and NVD in the avascular area, but it is not the best investigation because it does not show leakage, and it can also show a reduced vascular density index. So ideally, OCTA, it can be used to monitor the macular ischemia and give proper patient prognostic implications for the patient. Wide field imaging is also very useful in RVO because it can give us a peripheral non-perfusion detection. If you can do FFA on a wide field, it can give you a very good idea of missed ischemic areas which you may need to laser. You can also monitor for neovascularization, to guide PRP, and for treatment assessment. A 7-field photography or a single capture like this, which gives you a 200-degree view of the retina on a wide field image, reduces imaging time by about 60%. So it can detect about 2.3 times more peripheral lesions in RVO cases. So periphery is also very important in RVO. And this also helps us to follow up and enable more accurate longitudinal comparison of ischemic areas. Coming to the most common cause of vision loss in RVOs, macular edema. So in this picture, you can see that what happens is in CRVO or any RVO, there's hypoxia and inflammation, which can lead to development of multiple growth factors such as PIGF, VEGF, VEGF, inflammatory cytokines, which increases, and then all these lead to breakdown of the blood retinal barrier and formation of macular edema. It is the primary visual impairment mechanism in RVOs, and it can have a chronic edema, shows cystoid spaces with outer retinal disruption, while acute cases can demonstrate diffuse intraretinal fluid with preserved photoreceptor layers. Visual impact patients will typically complain of a central scotoma and metamorphopsia, and chronic cases may not have improvement in vision despite having a dry macula because of permanent photoreceptor damage. So it's important to pick up macular edema early and treat it early. Of course, anti-VEGF is the main treatment. I will come to that a little later. And prognostic factors can be baseline visual acuity and duration of edema, which can predict the final visual outcomes. Another important complication of retinal vein occlusion is ischemia and neovascularization. The capillary non-perfusion in the initial vascular occlusion, it leads to hypoxia, that is tissue oxygen deprivation at 2 to 4 weeks. And there's a VEGF release, which can lead to the formation of neovascularization, that is pathologic vessel growth. And this can lead to multiple complications such as vitreous hemorrhage, retinal detachment, or neovascular glaucoma. So key risk factors are extent of ischemia, poor visual acuity, and it's also more common in younger age. Neovascular complications can include neovascularization of the disc, neovascularization elsewhere, and neovascularization of the iris. Of course, like I told you, FFA is the primary mode of detection because only FFA can detect leaks, whereas OCTA can also detect more obvious neovascular complexes, although it does not detect leaks. Another very important vision-threatening emergency in RVO is neovascular glaucoma. So what happens in this is a fibrovascular membrane. You can see in this picture, typical NVI are present over the iris. So this leads to a formation of fibrovascular membrane in the anterior chamber angle and mechanical obstruction of the trabecular meshwork and secondary angle closure with Seneca formation. There's a rapid elevation of intraocular pressure. Patient will have severe pain and vision loss, and it does not respond to standard medical therapy. So emergency is topical steroids, atropine, intraocular lowering agents, and then of course surgically glaucoma drainage devices, cyclodestructive procedures, and early panretinal photocoagulation is very important for these ischemic retinopathies. If you're able to view the retina, you have to do a panretinal photocoagulation even in these cases. So neovascular glaucoma is something that should not be missed, and that's why at every visit of a RVO patient, you have to check the slit lamp for NVI and also look at the angles with the gonioscopy for NVA because even a small one can lead to the development of neovascular glaucoma. So goals of management in our RVO is one, visual preservation, that is maintain and improve the visual acuity through the regular monitoring, macular edema treatment, complication prevention, that is avoid neovascularization, and risk factor control, that is systemic disease management, including hypertension control. So systemic evaluation and risk factor control, there's a comprehensive assessment should be done to make sure you're ruling out any systemic risk factors. Of course, managing blood pressure, diabetes, lipid, and a multidisciplinary approach should be done with the ophthalmologist, cardiologist, endocrinologist, and all the primary care providers to make sure we are following standardized monitoring protocols with scheduling follow-up intervals. So when to refer, this is also a very common question that was asked earlier before the webinar. So young patient less than 50 years, we need to refer immediately within 1 week to do a full workup because these patients are at a high risk of having a systemic condition such as, even autoimmune diseases, so we need to refer them immediately. Bilateral RVOs also should be referred immediately. Recurrent RVOs within 2 weeks, and uncontrolled systemic risk factors routine within 4 weeks, but of course refer as early as possible. And suspected systemic disease also should be referred as early as possible within 1 week. So coming to the treatment, anti-VEGF therapy in RVO, the mechanism of action is the vascular endothelial growth factor, which is VEGF, is upregulated in retinal vein occlusion, like I showed you in the slide, a couple of slides before. It leads to vascular permeability and break down the blood-retinal barrier. So the anti-VEGF agents, what they do is they specifically bind and neutralize the VEGF molecules, so it prevents the receptor activation and reduces vascular permeability, decreases macular edema, and improves retinal architecture. So there are, of course, multiple randomized trials which have been conducted based on them. And the four main drugs that are used are ranibizumab, aflibercept, bevacizumab, which is off-label, but used very commonly in developing countries, and faricimab, which has a dual angiotensin 2 and VEGF-A action, which has been recently approved for RVO. So I'm not going into the studies because there are a lot of studies, but I mentioned them on the slide. And these studies have all proven that all these molecules are very useful for retinal vein occlusion. So how do we treat? We give loading doses. The initial phase, it's a 3 monthly loading dose. And then decision criteria is based on the disease activity score. And then you look at the success metrics, more than 50% reduction of the central retinal thickness by month 3. And then you monitor monthly. And after the 3 loading doses, you can do a maintenance phase of a treat and extend protocol, or you can also do as per need, as per the need of the patient. So this is also based on multiple decision criteria. But the 3 loading doses are very important. In faricimab, we do monthly inject 4 loading doses and then extend intervals based on the response of the patient. And CRVO usually often requires more intensive and prolonged therapy compared to BRVO. So steroid, of course, is one of the armamentarium that we have against RVO, especially in patients who are not responding to anti-VEGF over a long period of time. So we have a sustained release dexamethasone implant, which provides continuous anti-inflammatory and anti-permeability effects for about 4 to 6 months. And the Geneva trial suggests a good improvement of visual acuity and macular edema reduction. And it is used as a second line therapy. So anti-VEGF is first, but you see anti-VEGF not responding or you have a treatment failure, you can use this along with anti-VEGF as a combination therapy or just alone as well. There are, of course, contraindications where if a patient already has glaucoma, we don't typically give this, and if there's any hypersensitivity or infections. And we have to always monitor eye pressure and also inform the patient there's a chance of cataract progression and monthly OCT monitoring for macular edema resolution. So there are multiple choosing the right patient. I'm not getting into this too much. So based on the patient assessment, risk factor evaluation, treatment selection, and combination therapy can also be very useful. And switching criteria, let's say there's persistent fluid after 3 anti-VEGF injections or steroid responsive inflammation, and then you have to choose and change back into either steroids or anti-VEGF based on what is not responding. Role of laser. There's a traditional role earlier. Grid and focal laser were used a lot for macular edema and branch retinal vein occlusion, but current is anti-VEGF, is the first line for macular edema, if whether it's due to RVO or BRVO. And combination therapy, uh, laser augmentation for persistent edema despite anti-VEGF, yes, you can give laser. And the targeted PRP is combined with pharmacotherapy and hybrid approaches. And microsecond pulse laser are emerging as a selective treatment. So multiple studies such as BVOS and CVOS have all established guidelines for PRP as well. And the laser retains the role in pan-retinal photocoagulation for neovascularization. So PRP is standard for neovascularization, nothing. And for macular edema, the standard right now is anti-VEGF. So focal lasers used for discrete leakage points, which again is identified on FFA. And for grid laser, it's due to diffuse macular edema, creating a pattern of mild burns in a perifoveal region. It's not as commonly done now because, of course, we have other options available. But if you're doing it, we do it on slit lamp, and parameters are about 50 to 100 micron spot size and 0.05 to zero point 0.1 second duration and a light gray burn endpoint. It's generally performed only if there's still a failure after 3 to 6 anti-VEGF injections, and steroids are not considered for some other reason. And outcomes, we can expect a 1 to 2 line visual acuity improvement in about 60% of the cases. Pan-retinal photocoagulation is the most important treatment for neovascularization. So any ischemic RVO, it's a treatment of choice when you see retinal or iris neovascularization or neovascularization of the angle, and an established NV proven efficacy in regression of the new vessels. So prophylactic treatment, it was not recommended by CVOS, but in RVOs, of late, there are many studies, especially in BRVO, where there's very, very poor perfusion. You can do sectoral PRP in these cases, and just to prevent occurrence of retinal neovascularization. But routinely, it is only done when you already see the neovascularization is already developed. So technical parameters are 1,200 to 2,000 burns per session with a 500 micron spot size. And you can have a combination protocol of an anti-VEGF for acute edema plus PRP for ischemia. An endpoint is complete peripheral ablation with except the macula. So follow-up protocols in RVO. Initial visit, you do a complete ophthalmic examination, like everything I mentioned, and also establish an anti-VEGF injection protocol if you see macular edema. Then you do monthly visits from the month 1 to 6 with the visual acuity check. Repeat everything, including OCT, and you repeat monthly injections if needed, and then assess after the first 3 loading doses, assess based on the response of the patient. And quarterly visits, that is months 6 to 12, you give a maintenance phase and consider extending the treatment if you see no recurrence of the macular edema. And biannual visits, if done full diagnostic workout at every year, you can do visits to make sure and do FFA in case you suspect neovascularization in these cases. So it's important to monitor for neovascularization because it can develop. Patients may not have any symptoms. It can develop in the periphery, and patient will have no idea about it. So you can have regular dilated fundus examination, gonioscopy for angle assessment, like I mentioned. Wide field imaging is a very, very new, very important new thing in the armamentarium wherever available. Can definitely help pick up. And of course, always inform patients of what symptoms they can have, and always intervene early for these cases. So high risk patient identification is also important. Diabetic CRVO patients and those with prior PDR, require more frequent monitoring. Visual prognosis in CRVO is about 65% vision improvement, obviously better in non-ischemic than ischemic CRVO. And BRVO generally has favorable visual outcomes, especially if you initiate anti-VEGF treatment early in case of macular edema. And about 50 to 60% can have spontaneous improvement as well, according to the natural history. But the macular involvement is the key determinant of the final visual outcome. So we already spoke about bilateral RVO, so I'm skipping this slide and moving on to the next slide. So when you have RVO and cataract with glaucoma, we have to always time the surgery properly, IOL selection, concentrations for compromised eyes, and steroid response monitoring post-cataract surgery. And in glaucoma management, IOP control, medication interactions with RVO treatments, and surgical concentrations for combined pathology, and especially management of NVG as early as possible. And of course, combined procedures, we have to plan with optimal timing. So key education components are the patient needs to know that it's a chronic nature. This disease has to have a good follow-up. Patients have to commit to the treatment. They cannot miss one injection, and because they cannot miss one injection, show up after nowhere and expect the same visual benefit. Realistic expectations, procedure details, and follow-up importance. So always address the patient concerns, support resources, provide contact information for the clinical team, give them educational materials to clearly explain what this disease is, and use teach-back technique to confirm the understanding. So I'm just showing two cases of mine as the last few slides. So this is case one. This is a 51-year-old female. She presented with sudden painless decrease in vision in the left eye. The right eye was 6.6 and was normal, and left eye was 6.18. She has no systemic comorbidities. So as you can see in the left eye, there is a central retinal vein occlusion with a mild macular edema, but enough to cause a drop in vision to 6.18. So, and she was investigated and found to have protein S deficiency. So although we did all the regular panel, all of that came out negative, and she ended up having something which is, hypercoagulable state. So after one dose of aflibercept, you can see she actually responded very well, and her CMT was 275 microns. But as per protocol, two more loading doses were given, and she remained stable for 10 months after the injection. So you can see this after three injections, her macula was completely dry. So what happened is she traveled to a higher altitude place, and there's a recurrence of macular edema. So this is a very, very rare cause of recurrence of macular edema and RVO. And I gave her one more dose of aflibercept 2 milligram, and she did very well with that. But we also have to counsel patients to tell them maybe not to travel to very high altitude places, because hyperbaric hypoxia or hypoxia-induced autoregulatory vasodilation and altitude-related rise in hematocrit and blood viscosity and reduced vascular compensatory reserve in eyes with previous CRVO can lead to recurrence of macular edema. So this could have been the case of a physiological trigger in this patient, and so it's important to counsel these patients accordingly, because she was stable for 10 months before this. Coming to a very simple case, a real life scenario again, 31-year-old male, of course, young patient, so we have to investigate properly. Diagnosed with OSCRVO in the left eye and received 3 months ago injection. He already received elsewhere two intravitreal ranibizumab, and he was due for the third. He had come to me that time. He didn't have any macular edema clinically, but a lot of cotton wool spots, and you can see diffuse retinal hemorrhages. And but of course, due to stabilize, we gave him one more injection, and he maintained stable visual acuity, and there was no recurrence macular edema at 8 months post injection. So he responded very well, 6.6 vision, and his fundus also, you can see the cotton wool spots have significantly decreased. But important in this patient is a systemic evaluation. He was found to have hyperhomocystinemia, which I mentioned is one of the important causes of young RVO. So this patient again was on treatment for this, and that's important because we have treated ocular. Ocular is done very well, but it's important to also pick up the systemic causes, because RVO is a disease which affects these something in the body is causing the eye problem. So it's very important that we target both systemic and ocular in this in cases of RVO. So key take-home message is that RVO management requires early recognition, prompt treatment with anti-VEGF therapy, systematic follow-up, and comprehensive systemic evaluation for optimal patient outcomes. So thank you so much, and I will be happy to answer the questions. Okay, so when to start with anti-VEGF and when to wait for this treatment or any contraindications is one question. So when to start anti-VEGF? Of course, if you see any macular edema, you have to start anti-VEGF in the eye. There are no contraindications as such unless there is active infection in the eye for some other reason. So you just have to start as soon as you see macular edema. Now, like I mentioned, loading doses you give and then you treat them accordingly after that. Yes, usually a patient with BRVO, like you saw my patient, the patient responded very well with just one injection anti-VEGF. But even in that case, we should continue a protocol of 3 monthly injections. I usually do, at least in my clinical practice. And then after that, once you stabilize the eye, and then you can, treat and extend based on how the eye is responding. So are the monthly 3 intravitreal injections systematically done even if the CMT is stable after only one injection? Yes, like I said, yes, you do have to finish the loading doses and then uh, treat and extend only after the loading doses. Is there a way to diagnose the collaterals without FAF? No, collaterals are the best way to diagnose is the fundus fluorescent angiography. But of course, in case of obvious neovascularization, you can also see it on OCTA. But collaterals typically they will typically connect the existing veins to the sclerosed vessel. So you'll be able to see them correctly in that location. No, I do not laser around the ghost vessels unless I see neovascularization. So nothing required, just follow up in these patients. Yeah, NVI, how does it appear? It occurs because, again, because of ischemia, there's increased VEGF and leading to the formation of retinal NVI, iris neovascularization. Important thing to remember is that iris neovascularization is actually more common in CRVO because the entire retina is ischemic, right? So that's why in the anterior segment, you will see iris neovascularization, whereas in BRVO, you will typically more often see neovascularization in the retina itself. Yeah, NVI can regress if treated correctly. We have to plan PRP immediately in these patients and it can regress. And you can see NVI in other conditions, of course, proliferative diabetic retinopathy, you can see it, and you can see in multiple inflammatory conditions as well, you can see RVO. How does altitude and hyperbaric pressure? I mentioned in the slide already. That's how in my patient there was a recurrence of macular edema because of the multiple reasons that high altitude has caused the RVO to recur. Can we give intravitreal anti-VEGF when laser is not available in case of NVG? Yes, actually in some patients you can, but best option is PRP in these cases. It's absolutely compulsory to do PRP, but anti-VEGF can be given, especially another reason to give it is also when you cannot visualize the fundus. There are risks involved, but you can actually give in those cases. Yeah, RAPD is relative apparent pupillary defect, one of the most common important things when we do a pupillary examination. So yeah, please read about it. It's not just in this condition, of course, but it is an important factor in ischemic CRVO. So the single most reliable predictor of the final visual outcome in CRV, I would say, is macular ischemia. If there is a dry macula and but the retina and the FAZ is enlarged, is macular ischemia, you will not get good vision. And of course, the EZ disruption, that is the outer photo retinal layers disruption will also is also a reliable predictor of the final visual outcome. Can you preserve peripheral field by using anti-VEGF in ischemic CRVO? I personally, if there is no NVE or NVD, no neovascularization, I personally do not do laser. But there are some do not do lasers or give injection. But there are some studies where anti-VEGF has been given in ischemic CRVO. So I personally do not follow that unless, of course, there's macular edema. Controlling IOP by cyclophotocoagulation, yes, again, that's something which can be done in case of NVG when it's not being controlled by any other method, and we can do cyclophotocoagulation in those cases. The patient of CRVO within 3 hours, you will see what I told you, like a blood and thunder appearance, dilated and tortuous retinal vessels. We have to make sure there's no RAPD in these patients to make sure we're differentiating between ischemic and non-ischemic CRVO. And typically, what appearance I've told you, blood retinal hemorrhages, you will be able to see this within 3 hours of presentation. Yeah, RAPD in ischemic versus non-ischemic. In ischemic, you will definitely have RAPD, and non-ischemic, you will not have RAPD, and or it will be very mild. There is a neutral density filter, which is a quantitative way of evaluating RAPD, and that can be done in patients where you're not sure and whether you want to see whether RAPD is present or not in these patients. Gonio should be done at every visit. And if it's an ischemic CRVO, you will be seeing the patient monthly. So 100% gonna should be done at every visit, and based on the risk factor of the patient, how often you're reviewing him. Non-ischemic CRVO, obviously you can see, you can you don't have to see as close as you can. You have to evaluate ischemic CRVO, but non you have to do gonio at every visit because NVA is something which you cannot miss. Antiphospholipid antibodies need not be done routinely, but like I told you, bilateral RVOs, young patients, any history of thrombosis in the family, or any previous RVO in the other eye, or any of these things which do not fit into the normal criteria, then yes, you do have to investigate for antiphospholipid antibodies, but need not be done routinely. Yes, actually, there are multiple cases of RVO because of COVID as well, and sometimes COVID vaccine also. It is commonly seen, and there have been multiple reports on that. Any prediction from OCT to no conversion of non-ischemic to ischemic? I would say, I mean, not particularly, but probably OCTA. There could be, if there's a lot of ischemia noted on OCTA, then we can think about the fact that it can convert to ischemia. There is a question which says my today's patient was having counting finger in right eye, and other eye was 6'6". She wasn't hypertensive, wasn't diabetic, no history. What can be the reason? You have to evaluate her further. Like I told you, if you have ruled out the main conditions, and have you done dyslipidemia, have you done any other metabolic syndrome, anything? If all these are ruled out, go to the next panel of investigations. Make sure there's no other systemic cause causing it. Anything, any inflammatory markers, any autoimmune causes, etc., that can cause BRVO on the eye. So, which subtype of RVO has a higher likelihood? CRVO has a higher likelihood of developing NVG. RAPD is important because it can identify between ischemic and non-ischemic CRVO. Like I told you, role of optometry is when you're evaluating the patient, visual acuity is very important. RAPD is very important. Even an optometrist can pick up RAPD. And of course, when you're doing a slit lamp examination, you can pick up any NVI at least, even if you're not using a gonioscopy. And many optometrists do OCT. So, of course, to identify macular edema or any macular ischemia on OCTA, there are multiple roles for an optometrist to identify accordingly. And when a patient complains of sudden painless visual loss, you have to take it as something that is an emergency and see that patient faster than you would see the other patient and treat the patient as an emergency. In patients with ischemic CRVO, the presence of RAPD sufficient alone to classify the case as ischemic, or do you still rely on fluorescent angiography findings for definitive classification? Uh, I think RAPD is the most important factor. Vision, you can use the other modalities as well, and you can also use the presence of a strong RAPD, more than 0.7 log units of neutral density filters, definitely sufficient enough to classify it as ischemic. But also look at the other factors. Side effect of anti-VEGF, there are multiple. I've not really gotten into that because it's not the scope of this presentation. But that is the primary treatment for RVO with macular edema. In case of recurrence of BRVO, do we need to combine laser with anti-VEGF? Yes, we can definitely combine laser with anti-VEGF in case of recurrence of BRVO, or we can switch anti-VEGF also, or we can try steroids in these patients. When you see collaterals, can we stop follow-up visit? I would not stop follow-up visits, especially when you see collaterals develop in BRVO. Just because one area there is collateral doesn't mean another area cannot get BRVO. That's one important thing also. So you have to continue, but maybe you can extend your follow-ups. You don't have to see the patient very frequently, but I would not stop the follow-up visits just based on the collaterals. Is pan-retinal photocoagulation a last stage of treatment? So I mean, it depends. Not last stage as such. When you see neovascularization, you can immediately laser the patient, and it's one of the most important stages of treatment for the patient. Would not say last stage. Patient can still have good visual prognosis if you identify NV neovascularization early, and administer the pan-retinal photocoagulation and spare the macula. I'm sure the patient can still have a good visual prognosis. So brolucizumab in treatment of RVO, I don't give it because it is not actually approved for RVO, and it can cause inflammation. So I've never given brolucizumab in the treatment of RVO. But there have been few studies on it. You have to be very careful about your patient selection. The patient has high IOP and RVO. When can you start the treatment? Which should be first? Both. You have to start both treatments together. If it's just RVO with no macular edema, there's nothing you're going to do specifically. You have to just treat the underlying conditions, right? So intraocular pressure has to be managed in these patients. So collaterals I already explained. Somebody's asking what collaterals is. It is pre-existing venous channels that occur between the existing vessels and the sclerosed area that help to prevent the complications of RVO. So they are good vessels that develop due to the natural course of RVO. The patient with retinal traction, and yeah, if you give anti-VEGF in retinal traction, the patient can develop retinal detachments. You have to examine the retina carefully and then decide whether anti-VEGF is really beneficial to the patient or not. Otherwise, they can end up with a retinal detachment. So rescue grid laser can be used for RVO when even after 3 to 6 months of constant anti-VEGF injections, you're not seeing any improvement, and then you can try a rescue grid laser in these patients. Not very commonly done these days, but it's definitely an option. RAPD and normal fundus, please rule out retrobulbar neuritis, any kind of optic neuritis. It's very important. Again, it's not in the scope of this presentation, but that's what you need to rule out. Okay, so thank you so much. Most of the questions are repeat questions. So thank you so much for having me. If anything else, please, you can mail me on sashu23@gmail.com if you have any other queries. And thank you so much for this having me for this presentation. Have a good day.